All right. Well, I'll go ahead and start talking about this. I should be there in about probably 3 minutes, but again, I don't want to hold people up. We find ourselves kind of in an unprecedented time in a number of ways, both because of, I think, frankly, societal changes to a large degree brought on by social media, as we touched upon in the past, but certainly the development of the SARS CoV-2 virus is a not insignificant issue. And to some degree, medicine and society's response to it, I think, has, instead of helping, has maybe compounded things a little bit. And so as we, kind of try to, just as physicians, and I think as surgeons, we are, physicians first. And as physicians, I think we should, I think it's incumbent upon us to have a significant understanding of this disease process, which is both so persuasive and so significant. Even if it's not something that we deal directly with in our practice, we're certainly dealing with it indirectly and a number of instances directly. So just let's go back to basics and what is a pandemic, just to start with. Okay, used as an adjective, it can be used as a noun. Where we're talking about a disease which is prevalent over an entire country, or in some instances the world, or used as a noun, it can be an outbreak of a pandemic disease. So yeah, I thought it would be very simple to get this lecture started as I was, working to develop it. And then I quickly saw how complicated it was going to become, because even getting the damn definition down, people can't agree. You go online and there's all this controversy and outrage about the World Health Organization changing this in order to meet this criteria, so that then certain funds would become available for this, or certain preventative measures would become. So we can't even freaking agree on the definition of pandemic in our current state of things. But I think in trying to look at most of the previous data, at least that's out there before every damn thing became so politicized, basic definitions of endemic, epidemic, and pandemic. Okay, endemic is from the Greek, meaning within people, which is basically an infectious disease occurrence that is kind of constantly maintained at baseline with a geographic area without external input. So this is a disease process that's basically maintaining somewhat of a steady state throughout a population. It's not being eradicated, it's not being overcome by herd immunity, but it's also not escalating. Its R value, as we're going to see, is essentially 1. So most bacterial pneumonias, things of this nature, would be things which are endemic in society, but then you do see seasonal fluctuations to some degree. Epidemic, more pertinent to today's conversation. Epidemic is from Greek, meaning above people. So basically this is, and these terms are typically used, they'll sometimes be used to apply to non-infectious disease, but speaking precisely, these are typically reserved for infectious disease processes. So this is an infectious disease occurrence that exceeds the normal or expected frequency, specifically in a community or region. So it's an infectious disease. R value, as we'll see, is greater than 1, meaning that each person that is infected with it infects more than one other person, and so the disease is spreading. The infectious disease is increasing, but is confined to a community or region. And pandemic is basically the same thing, except it's become more widespread, and specifically it's crossed national borders, or more commonly, even across continents, and that's the common utilization. So essentially, a pandemic is an infectious disease process whose R value, whose rate of spread, is greater than 1, meaning it's increasing and it's spread to a point that has crossed global geographic lines. And so just in looking at a pictorial representation as far as endemic, is kind of confined to a certain area, stable rate. Epidemic is in certain areas and is increasing, and pandemic is at least relatively low. Why does this occur? What is the pathogenesis of epidemics? It can be multifactorial, but usually involves one or more of the following mechanisms, where you have an agent which is mutated, so it's become more virulent, or an agent which has become more prevalent for some reason. That might be due to societal issues, such as the global movements that occurred with World War I that contributed to the influenza epidemic or pandemic of 1918, for example. The introduction of the agent into a new environment. An example here would be, smallpox, which was brought by the Europeans when, they came to the New World, which, wiped out many of the Native Americans, which were here. It can be an enhanced mode of agent transmission, again, related to mutation, or can be due to a change in susceptibility in some instances of the host population, related to factors that increased host exposure or new portals of entry. The mechanism with most of the epidemics and pandemics most recently, which have been the most significant concern, have involved basically a zoogenic mechanism, where you have some crossing between a virus typically found in an animal, and then through the spread of wet markets or kind of weird ingestions of people eating camels and other things that maybe shouldn't typically occur. Then you get a mixing of the zoogenic or the animal viruses with human, and mutations can occur, which then we don't have a resistance. And that's thought to be the mechanism or the pathogenesis for both SARS CoV-1 and CoV-2. So I'll pause just for a second and walk in, and then I'll be with you in person here in just a second. Okay, so I think it's always helpful, or in many instances anyway, helpful to look at history when we look at a topic such as this, because there's I think a lot that can typically be learned from history, and the mistakes of the past that we're doomed to repeat if we don't learn from them. So just in looking back at some of the pandemics in history, Yersinia pestis, or the plague, has killed more people probably than anything else in history, at least in a certain focal amount of time, and is definitely a historic pandemic of significance and interest. I think smallpox and influenza, I think, are probably the three most pertinent here. So just looking at these, just in brief, Yersinia pestis, or the plague, is kind of fascinating. I actually ran across this lecture series called The Black Death, which is available on Amazon, which I've got a little pictorial of it down there in the right corner as you face your screen. This is a PhD lecturing, a Purdue PhD lecturing, and she's an amazing lecturer. I mean, literally, it held my attention through 24 episodes, and it's just her lecturing. I mean, it's that good, but it's really a fascinating look at the history of Yersinia pestis and how it has affected the world. And really, you can go back and argue that it contributed to the end of the Roman Empire. It contributed significantly to the end of feudalism. It contributed significantly to the spread of both the Muslim and the Christian religions throughout the world in the medieval times. And it also ultimately led to some restructuring of the Chinese government and society during the time of the third plague. But people think of the plague and they think of this period that's been referred to by the lay people and stuff in history as the Black Death or the Great Pestilence, or a number of other appropriately dramatically sounding terms it's gone by. But really, there were three periods of plague which occurred. The Justinian plague, the Black Death, which is the one most commonly known, which was in the mid-1300s, and then the third plague, which really continued to some degree, faded, albeit at a gradually diminishing rate, until the 1960s in parts of Asia. And there's, in similar fashion, three forms of Yersinia pestis: bubonic, which few people would survive from historically, and then pneumonic and septic, which were universally fatal. Even today, with antibiotics, of course, this is a bacteria, so we've got antibiotics that work against this. It still carries a 10% mortality, and there's still, somewhere around 500 to 600 cases which occur a year internationally. In looking at the period when Yersinia pestis was most significant, though, between the period of 1346 and 1353, this was an amazingly devastating disease, killing somewhere between 1/3 and 1/2 of the, quote, civilized world at that time. I mean, we're worrying about, and appropriately so, something we're going to see around a 2% case fatality ratio. I mean, this is like 50% of the freaking known world dying from this. People laying in the streets rotting because there's nobody to clear the bodies away. I mean, it's just amazingly horrific to even kind of try to wrap your mind around. I mean, there are, entire parts of Europe where land was unclaimed because the tradition of the time, well, still today, people inherit the land. There's nobody left to inherit it. So it's just sitting there untended. It was actually a huge societal problem. What are we going to do with all this land that's just growing up because there's nobody to take care of? And so this, is I think kind of worth a look. You might want to watch an episode too. I think it just helps give us some perspective, which, over time, we lost, I think, as far as how bad this was. Trouble. Smallpox is also something that's, kind of been, due to the efforts of, thousands of people over years, has become eradicated. One of only two really infectious diseases which have ever been eradicated. The variola virus, responsible for 500 million deaths in the last century, carried a 30% mortality. And starting with Edward Jenner on down through the the efforts of public health and a number of providers, was formally eradicated in 1980. The last person to become infected, I believe, was 1968, and he got it from basically a vial. It wasn't really acquired in the community at that time. Probably the one the huge pandemic, that is perhaps most pertinent to, the situation we find ourselves in now with SARS CoV-2 is the 1918 influenza pandemic, or sometimes going under the moniker the Spanish flu. This was an avian, so again, going back to, animals and transmission that was initially in birds. And then got transmitted to the human population, an H1N1 variant of influenza. And a third of the world became infected with this. So 1 out of 3 people in the world at this time became infected, ultimately resulting in 50 million deaths worldwide, 675,000 deaths in the United States. It's really interesting when you look at the patterns of death in this population with this virus. The first and the third makes sense, right? Extremes of age tend to be more susceptible to dying from disease processes. So less than 5, greater than 65 had an increased risk of death, which makes sense, right? 20 to 40, though, not so much, right? Those are people in the prime of their life that should have the greatest resistance. And this has never been fully explained, but, just common sense would probably tell us that perhaps there was a similar H1N1 influenza, which had been transmitted over, a period of years, that people that were older had come in contact with, and so maybe had a partial immunity. However, as you age, your resistance decreases, maybe despite having some immunity. I don't know, but it was very interesting that there were 3 peaks which occurred with this H1N1 influenza, and right in the middle there were your 20 to 40-year-olds. Now, how much of an impact was World War I on that as well? More of these people were together, and more of them were perhaps under circumstances which might decrease your immunity, being out in the field and things of this nature. And so certainly that may have contributed as well. And certainly the effect of World War I was significant on the spread of this, as you had a lot more transcontinental movement than you would have otherwise. There's a few interesting, if you go back, just look on the internet, there's a few interesting like posters and things from this time frame, basically bemoaning the fact that this damn influenza, we can't get back to killing each other in the war, in essence. So it had a huge effect of that. Both World War I had an effect on the influenza had an effect on the war. And so social distancing, not a new phenomenon. Okay, here 1920, February 1920, Admiral Halstead, an edict for those in the Navy. First of all, educating them how influenza is spread from the eyes, nose, mouth, and is saying avoid people that have it. If you cough, don't cough on other people. Preferable to cough into a handkerchief and then or a napkin or something, and then dispose of said thing. Don't share drinking cups. Okay, a little bit of social distancing there. All right. Don't share the beer mug. Most importantly, do not, I repeat, do not expectorate promiscuously. I was unable to find any internet pictures of promiscuous explorations, but it did take me to some interesting websites, which I won't share. Don't stand close to another person while covering. So yeah, so social distancing might look a little bit different back then, but masking's not a new thought. This is a barber in Cincinnati, and he's following what was the recommendation at that time of masking. So so many of the what we're going to call NPIs, or what the CDC calls NPIs, or non-pharmaceutical interventions, basically things to do to try to prevent the spread of disease. These are not new concepts which we're trying to employ now. It's interesting when you look at most of these pandemics and epidemics that you'll see this, and I still don't have a full understanding of this, and that's one of the reasons I was late this morning, and one of the reasons I've kind of struggled, frankly, over the last few weeks of trying to create this presentation, is there's a lot about this stuff that I just don't know, and I'm not I have no real training in epidemiology and stuff, and boy, the mathematics and stuff gets pretty complicated. At the same time, from a fairly simplistic standpoint, this curve is pretty consistently replicated with most pandemics and stuff, where you'll see a little bit of prodromal period here, where you have a little bit of stuff happening in the background, and then it reaches a critical mass, and you have a sharp uptick in the number of cases which occur, which is shadowed by the number of deaths which occur. So the deaths always lag behind the noted infections, which just makes sense. But then you get the second peak over here pretty consistently, and so a number of epidemiologists and infectious disease experts have been saying to expect essentially what we're seeing now, which is this second peak right here and stuff. Now, usually this is somewhere between 1/4 and 1/8 of what this is. I think the concern that many people are having now is in this instance, actually, are we seeing more like this? Is our second peak actually going to be worse than the first one? And if so, what's the story with that? And I think that's one of the things that hopefully we can explore, and that we need as a medical profession to explore and try to understand with this particular virus. And this is just another similar curve you'll see out of England. And when you look at, frankly, most viruses, you see some variation of the same phenomena very frequently. So I think what we're seeing is not unexpected. I think what we're seeing, though, the degree of it might be unexpected. The problem is that we have really become, and that's what I'm going to emphasize most of the last time, we're very unscientific about this whole process. And as a result of that, our data is a mess right now. Our data is particularly a mess in the state of Ohio. Okay, to be counted as a COVID positive patient in the state of Ohio, what's the criteria? Somebody tell me.
Like in terms of deaths or something, like COVID death?
So when Governor DeWine comes on and says we've had this many deaths, or when you get that email, or this many cases, what's a case? What's a case? One positive test. Okay, that's not the only criteria. What else will make you a COVID statistic here in Ohio? Because presence of symptoms without a positive test counts. You report that, case. What else? Doesn't even stop there. If you report in close proximity to someone that has COVID and that gets reported. So, Dr. Adengast, you're a case, Leslie. Whether you test positive or not, you're a case.
I'm a statistic.
You are. But a very special statistic. And we're not going back and correcting for those things. Now, I'm not saying that to be hypercritical or to be condemning, but I'm saying that to give us a realistic portrayal of what's going on, particularly in Ohio, because it's just very hard to tease out what is actually happening and what's not happening. I think that clearly, as we work here in the hospital, we can see that something's happening, right? I mean, for the deniers of this being a significant issue, I mean, I think that flies in the face of the reality of what we're seeing. At the same time, for the people on the opposite side of the spectrum, who I would call the hysterics, I'm not sure that the numbers are as bad as they look, frankly, and for reasons that. But it's infuriating because we don't have good numbers. The CDC has a very sane way of counting these cases. And frankly, if you have followed this all along, the one thing that I would have said, I haven't necessarily agreed 100% with everything. I have to argue that the CDC has been a center of the road and a voice of sanity in this entire process. And if we would just maybe all follow the CDC guidelines and recommendations instead of Governor DeWine doing this and the governor of Michigan doing this and Trinity wanting to do this and this set of progress says that we got all this confusion and stuff. And if we can't even count the cases, or hell, we can't even define what a pandemic is for sure without arguing. If we would just maybe the CDC, who probably, along with the WHO, and frankly, I trust the CDC a little bit more, if we would maybe just stick with those guidelines at least, I think we'd all be a lot better off. Because right now, I don't know what's going on in Ohio. It's really hard to say the way that is being counted. So these are some of the pandemics in history. I think it's helpful to just at least have a rudimentary understanding as you look toward this. But what's happened more recently? There is SARS CoV-2 is not the only epidemic or pandemic which has occurred in the 21st century. There's a number listed here. Ebola, a number of us remember, big deal there. I mean, case fatality ratio, 40%. Again, we're looking right now, SARS CoV-2 case fatality ratio is 1.9%. Okay. So Ebola, that's more like the plague, right? I mean, not all the way there. It's not 95% like Yersinia was pre-antibiotic, but that was a really big deal and something that was really scary. Yellow fever, we don't see it here in this country. So I think it's underappreciated, underrecognized, but again, something that's, greater than a 30% mortality in China and Brazil and other places where it's occurred. But most pertinent and germane to what we're currently dealing with probably is SARS, referred here, or SARS CoV-1, which was the 6th coronavirus recognized to infect humans. We're now on the 7th, which is SARS CoV-2. And this occurred back in 2003. And we can see that case fatality ratio was pretty high, almost 10%. But only ended up with 8,000 cases total. And that is kind of not the precursor, but is the most similar virus, to the SARS-CoV-2 that was important. In the Mideast, didn't hear a lot about this, but there was also this MERS virus, or Middle East Respiratory Syndrome coronavirus, which I'd never even heard of before. Anybody even hear this happening? Did you? Okay, maybe I was just less sensitive to the news and stuff. So with coronavirus, there are currently 7 coronaviruses which are infective in humans. So, CoV-1 and CoV-2 aren't the only ones. There's the MERS virus, and then there's 4 others which have been recognized but have not led to significant syndromes or pandemics. So what was the story? What went down with SARS-CoV-1? In 2003, you can see here in the orange, I'm sorry, this I didn't put the, oh yeah, no, there's that. So total cases. So this is running cases which occurred, ended up being, like somewhere around 8,000, depending on kind of how you count them. You can see that they kind of peaked in this fashion. Didn't really see much of a bimodal curve in this one. And then the total number of deaths ended up being, 810 patients. The big difference between this and SARS-CoV-2 was that it did not seem to be spread from asymptomatic patients. So the only patients that transmitted this were the patients that got symptoms and got pretty sick. So from a infection control standpoint, it was a fairly simple process of just putting these patients in isolation, taking the necessary precautions for those people which were interacting with them and caring for them, and SARS-CoV-1 kind of went away. The challenge that we're facing with SARS-CoV-2 is that there seems to be at least some degree of minimally symptomatic and or asymptomatic transmission of the virus. And so it's not the simple thing of, just you're caring for the patients being able to isolate them. Because, there's, you start to get into very difficult questions as far as individual rights and the societal response to, a viral outbreak like this and individual rights, right? If you're sick, I need somebody to take care of me, Yeah, put me in a room and people come in with gowns and gloves and whatever stuff and help me get better and we won't transmit the disease. On the other hand, if I'm not sick, I don't know that I'm real keen on being put in a concentration camp. I mean, that's how people are going to look at it, and I kind of get that, and so that's more difficult. How do we manage that? It's the balance between and the overall good of society and the individual's good, right? And where's that balance? And that's difficult balance sometimes. I mean, where, I think self-quarantining, I think makes sense. Things such as what has been advocated, including by our governor, your kid gets sick at school. If you've only got one bathroom in your house, your child doesn't come home. They go to this camp we'll build out at the fairgrounds until, we're sure what's going on. Now that's some scary shit right there. Somebody talking about taking my kid from me, the good of society starts to, my enthusiasm for that starts to wane a little bit. And, those are some of the mandates which have been, proposed. At the same time, seeing, death rates, like, you could see if let's say, you know, SARS CoV-1 had a mortality was about 10%. I mean, 10% in the United States, man, that's a lot of people, you know. So where's that bound? Again, fortunately, so SARS CoV-2 has, in some ways, is not as bad as SARS CoV-1, right? It doesn't kill as high a percentage. The vast majority of people, particularly the people in our age group and stuff, the likelihood of you dying from SARS CoV-2 is, you know, probably around 0.02% or something. I mean, it's an astronomically small chance. The vast majority of deaths occur, you know, in the elderly and stuff. But the difficult thing about it is it does seem to be, to some degree, and I think it's, and this is one of the things hopefully we can look at, but, you know, what is the risk of spread from an asymptomatic, you know, or minimally symptomatic person? I don't think it's defined, but I think it's increasingly recognized that it happens. And that's a downside, a real downside of this virus as compared to COVID-1. So some epidemiology that is painful. Well, it's not that painful, but any of this math and stuff is painful to me. So I found it painful to go through a little bit, but just keeping it as basic as I can, because I certainly am not capable. Some of you all are probably much better equipped to have a good understanding of this than I am. But the basic reproductive number is the most fundamental epidemiologic number. That's just the expected number of cases transmitted by a single infection when nobody in the population is immune. Okay, and so if your R0 is, you know, less than 1, if it's transmitted only to, then that's a disease that's going to die out, right? If your R is very high, then you're going to get a much higher number of infections. Just, you know, in doing the math, if you have an R0 of 3, meaning essentially, if I get an infection, the statistics are that I'm going to, on average, transmit that to 3 other people, you know, before I get better or die in some instances. That's the thing about really deadly things like Ebola and stuff. To some degree, they're not as much of a problem societally sometimes because they tend to stay a little more confined because everybody dies that gets it before they have a chance to, you know, spread. But you can see the difference. How can put them all with me? R0 of 2, 128 infections over 1 month from 1 infection. R0 of 3, 729 infections over 1 month, starting from 1 infection. Now, it immediately gets more complicated because it's very seldom that you're in a population that there's not at least some immunity. And different people have differing levels of susceptibility to infection, not just due to immunity, but often due to other factors. We know our genetic makeup makes us more susceptible to others. So then it gets more complicated. So you add in numbers like the S numbers, the proportion of the population who are susceptible, and then you factor that in. And again, if you're at a flat rate, it's endemic. If you're lower, it's, you know, decreasing. If you're it's higher, then you're going to be increasing. So just to give you a basic idea, what are some R0s which have been you know, recognized in the past? Measles is one of the worst. I mean, it you know, if you have, you know, a naive population, you know, 1 person can spread infection typically to around 15 people. The R0 for SARS CoV-1 was just a little bit greater than 1 in most of the series, although some were much lower. With CoV-2, it seems to be somewhere between 2 and 6 if there's no mitigating factors taken whatsoever. So again, what does that say? That says, on average, if we're doing absolutely nothing to try to contain the disease and I've got SARS CoV-2, I will spread it probably to somewhere in the ballpark of 5 people. Again, that doesn't sound like much, but then you start figuring, okay, well, if it's 3, that's 729 infections, and you can see how things can logarithmically increase, you know, pretty quick. So that's where the concept of social distancing and quarantines and isolations, and I think more on the fringe edge and less evidence-based edge, lockdowns, which we'll talk about, you know, come in. What are we trying to do? We're trying to decrease that R number, right? We're trying to impact on that R number, not by changing you can't change the virus itself, but what you can do is you can spread the number of, you can change the number of social contacts that the person has, and thereby the instances in which the disease can be transmitted. And by so doing, flatten this curve. That's the flatten the curve thing that we've heard so much about, right? What is the curve we're seeking to flatten? The rate at which the disease spreads. The surface area, however, you have to recognize under the curve does not change. Okay, so the total number of people infected here is not changing. It's just the rate at which it's changing, which is nonetheless still helpful to some degree because it prevents our medical systems, from becoming overwhelmed. So this was a very appropriate thought process, which we had early on, flattening the curve so that we don't become overwhelmed, so that the people that become symptomatic and sick, we have resources to take care of. Somewhere along the way, though, that gave way to no death being, tolerable. Every death is tragic, but the reality is that when you have a virus like this, people are going to die, and you have to be a mature adult to be able to accept that. Unfortunately, an increasing amount of society are not mature adults, and they're just filled with outrage about everything, and everything's somebody else's fault. But the reality is that you can flatten the curve all you want to. You ain't changing the surface area under it. All you're doing is giving the ecosystem time. Now, that might ultimately save lives, right? You get a vaccine, find other treatments and stuff. So it is a gating factor that not just prevents the system from becoming overwhelmed, but does have the potential to save lives as well, if we're able to, accomplish things to intervene. But this concept of flattening the curve, which is epidemiologically sound, has kind of mutated into we're going to save everybody from COVID. And that's just not reality. Sorry. And, as you think about all the factors which go into this, trying to predict what is going to happen with a virus like this is exceptionally complex. And so we went from that simple S times R formula to something that looks more like this, which is in and of itself, as I'm told by people much smarter than me in regards to math, is in and of itself a gross simplification, and that you really need something called delayed differential equations, which I don't even know what the hell that is. But this is really complicated to try to predict how this is going to ultimately play out and what society's risks are going into this, because there's so many factors which come into play. And in order to do the math, you have to make a number of assumptions. And any result you get is dependent upon the reliability of those assumptions. And if even a couple of those assumptions are wrong, you can kind of start to go astronomically wrong. And to some degree, that's what happened, at least early on, particularly with this study. This is what has become known as the Imperial College model of COVID-19. It was funded by the World Health Organization. The lead author is an epidemiologist, sort of, named Neil Ferguson. This is a guy whose formal training was actually in like astrophysics or something like that. But he, due to a result of a tragic death of a friend from HIV, he became interested in mathematical biostatistics, and had gained ultimately a university professorship in that, and became influential in the European biostatistical community, and he was the lead author on the study. And one thing which I want to be careful of is everybody, one of the things, if you saw my letter, I don't know how many of you read it, but one of the things I bemoaned was the fact that in society, we're not listening to each other right now. We're shouting at each other, and we're demonizing each other.
people we disagree with, they're inherently evil, instead of, maybe I can learn something from them. They've got a different perspective than me. Maybe there's a reason for that perspective. And if I sit down and listen. So I want to be careful not to demonize this guy, which he has been in the press some. I think some of that's frankly justified, and I'll share why. But at the same time, I don't think he went into this with any ill intentions. And much of what he said has also been blown out of proportion by the media. That's the problem. If you look at what they actually said in this study, was they said that if we do nothing, they predicted 550,000 deaths last spring in the United Kingdom and 2.2 million deaths in the United States. Now, with some common sense social distancing and stuff, you can cut down on that. Or if we do a lockdown, we can get it even lower. And so how did this get reported in the media? This came out March 17th. The headlines are out there. 2.2 million people predicted to die from COVID in the U.S. Over 500,000 Britons will die, epidemiologist said. This type of stuff. And it had quite the effect. And this was not the only study, but this was really the one that shook everybody. There was another one by IHME that was similarly off and similarly shook people, but this was really the one. And you can look at how views changed, very rapidly. Dr. Inglesby, a very respected infectious disease physician at Johns Hopkins, in January of 2020, large-scale quarantines for this novel coronavirus will be ineffective and could have significant negative consequences. After the Imperial study comes out, lockdowns should continue until we see a decline in new cases, widespread testing, and routine masking. Keep them locked down. He said lockdowns won't help in January. Then after that study, we got to stay locked down till we got a vaccine. Probably nowhere more striking than Governor Cuomo in New York. March 19th, he hadn't heard about that study yet, or hadn't read it, I guess, yet. There is, I think he even said, let me repeat, there is no quarantine planned for New York. Less than 24 hours later, quarantine, lockdown. This is the most drastic action we can take. Non-essential businesses are to be shut down starting Sunday. 24 hours completely changed the perspective, as a result of this. President Trump, similar fashion, went forward lockdowns. The Prime Minister of Britain, and so it's hard to overestimate the impact of this study. And there are some real problems with it because at that time nobody could look at their methodology for coming to these conclusions. And finally, when some people from Google and Apple got permission to look at it, there were significant flaws in it, at least as reported by those companies. And I think that's been recognized. And so that caused people to kind of look at this guy's history. This was not the first time he had given similar predictions. With the prion disease, back in the late 1990s, predicted 150,000 deaths, actual deaths 2,000. Swine flu predicted 65,000, actual 457. Bird flu, 200 million predicted, actual 455. These mathematical models are fairly unreliable, to say the least. Now, one will argue, okay, no, thank goodness everybody listened to him because look how bad it could have been, and we're so much better off now, and so, here were the projections. You see the United States there, depending upon the day, and looked at somewhere around 2.2, 2.6 million, as of, May, it was more like 83,000. Say, well, but we put many of those processes into place, and so we did mitigate it. But the Swedes said no. They didn't do any of those things. And as you can see, the projection was just as bad there in Sweden. And so the mandated lockdowns and things which came about and were, forced on the country were done so on a mathematical model that is now shown to be flawed. And most importantly, it didn't seem to make any difference that those things were done. Because you look in Sweden where they weren't forced, the outcomes are actually better. If you look at the mortality in Sweden as compared to the US, it's much better. Now, that's unfair to some degree. You can't say it's just that. I mean, lockdowns in the US versus not, mandated lockdowns in Sweden. I mean, there's other parameters that matter, right? Okay. If you've got a society that has more diabetes and more obesity, as compared to, one that doesn't, I mean, that's going to be a factor. So there's all these other factors in there. But the point is that these predictions that led to some of these rigid lockdowns were grossly inaccurate. This was actually predicted by an Institute of Medicine report, which came out several years prior, that said these models should not be used. They've not been reliable in the past. And there's a real risk that if we use them, we're going to bring about interventions that, number one, may not help that much, and they may hurt. Because that's the problem with these things. If we could do these things, and by these things, I'm referring specifically to lockdowns. And I'm not saying that lockdowns might not help to some degree. I mean, they could conceptually, but at what cost? I can cut down the incidence of pancreatic cancer in the population if I take everybody's pancreas out, right? And, well, I don't think we should do that. Well, you don't think pancreatic cancer is deadly? Pancreatic cancer is deadly. It kills most people that get it. Why are you not, you evil person, saying that? It's not. No. We're saying that the unintended consequences of taking everybody's pancreas out is going to grossly overcome the benefits. You might save one or two people that would have gotten pancreatic cancer, but you're going to kill a lot of other people with the diabetes and things. The point is that we have to be adults about this. We have to be scientific, and we have to recognize everything. Risk, benefit, ratios. Okay? Safety is the most important thing. I don't think so. If safety was the most important thing, we never would have fought the Revolutionary War. Safety is important, but there's also other factors as well. But to come back to this point, we have to make, decisions on treatment. All of it's risk-benefit ratio. And so if we could do lockdowns with no harm, great. Because there's probably some efficacy to it. I can't argue that if people aren't seeing each other, but the financial devastation which has occurred, the depression, the increase in crime, all of these are very real blowbacks and unintended consequences that have had significant impacts on people and have to be weighed in the balance and considered. And the Institute of Medicine actually, way back in 2006, raised the alarm that if we're purely going off the base of these mathematical models, number one, they're unreliable, and number two, we're going to see blowback. We're going to see unintended consequences. And this guy became, frankly, and again, I don't want to demonize him, but, if you've got this level of, credibility or influence, and you're advocating, because he advocated vigorously for hardcore lockdowns, and then within 2 weeks he violates it himself, and he's violating something else too, and he got caught, So, and again, I'm not trying, I'm not perfect either, not anything like this, but none of us is perfect, right? But as physicians, we do have an obligation to, I think, live our lives in a fashion that's consistent with the message we're preaching to our patients. We can't be hypocrites. So in any case, beware of any study frankly, that is a mathematical model. And I'm just going to skip forward here. Here's a nice study looking at that in the British Medical Journal, which basically looked at 66 prediction models. This is a meta-analysis. And they found that basically nothing worth it. So all of these papers that talk about we're modeling this, we're modeling that stuff, be extremely wary of those. I'm not saying they're entirely worthless, but the literature right now would say they're pretty damn close to entirely. Probably the only one that has shown any efficacy so far, and this is where I really got a time sink on this, is because I tried to understand this stuff. That was a mistake. That was like 2 days of time sucked. But this guy named William Farr, back in I think it was 1860 something, he described this Farr's law. And that model, not this elegant differential diagram that somebody came up with in the 1860s, has been shown to be the most predictive. For me, as a simplistic surgeon, the essence of it, and it's much more complicated than this, but the essence of it is that the infection curve is going to look like this, the death curve is going to look like this, and they're going to be like this. And so you can kind of predict where you're at on the incidence curve based on where you're at on the death curve. Because, as Farr said, the death rate's a fact, everything else is inference. And so the point here is, the point he made is, unless you've got 100% sensitive, means of detecting, 100% sensitive, 100% specific, means that all of your data is probably to some degree going to be, a little bit off. But your death rate, if you truly knew they died from COVID, is a good predictor model. And this has been looked at in the more recently. It's been found to be the one modeling tool which is perhaps valid on prediction, at least once the process gets, or is a little bit kicked off. So you may hear more about, Farr's law in the future. But it's not just important how many people get it, it's how important, it's important how significant it is to those that get it, right? So what is the fatality rate? The infection fatality rate and the case fatality rate. Important distinction, okay? Because again, this is something that has been massaged or misunderstood in the media. The infection fatality rate is the death rate in all infected patients. So that's symptomatic, asymptomatic, and undiagnosed. What is the chance you'll die from COVID? It's somewhere between 0.15 and 0.4. All right, is what we know now, which essentially equates to somewhere around 1 death in between 250 and 650 people infected. How old you are and what your comorbidities are significantly impact on that. Such that young and otherwise healthy, your chance of dying from this is pretty close to zero. If you're an elderly, if you're 90 and you're diabetic and you've got COPD and you've got, what else did Dick have? Diabetes, like my wife's uncle or great uncle did, then your risk of dying is quite high. And when we heard he went on the ventilator, I said, he's dead, because we know that all comers, once you go on the ventilator with SARS CoV-2, 80% mortality. With him with those comorbidities, I said he'll never leave the hospital, and he died last night, actually. But the infection fatality rate is not very high, nor is the case fatality rate as compared to some things, 2% basically, rounded up. And, frankly, not a huge amount different here as compared to a relatively poor village in India, because that study's been done. It was published about a month ago. Mortality rate in an undeveloped or developing, I think is the politically correct term to say, but basically a place in India that doesn't have near the resources we do. About 3% of the people die. Here, about 2% of the people die. So not that much different with all that we've got going on now. In fairness to them, there's some other things which mitigate that, but just to see where that's at, it does vary depending upon the country. I don't know what's going on in Mexico, very high there, but this is the case fatality rate, just looking at different countries. And here we are kind of, more on the lower side, but not the lowest. Okay, and then just in the last couple minutes, I think it's important to have this, and then we'll put this on the side. We had very well thought out plans on how to address this type of a situation, thought out by very smart people at the CDC, and WHO has a similar one. And again, the whole goal, recognizing, is to flatten the curve, give healthcare systems time to respond, and don't let the system be overwhelmed. Maybe give some time to come up with a vaccine or antivirals or some other type of intervention. But recognizing, again, that the area under the curve is stable. And this was from the 2007, and then subsequently, I'll briefly show that they updated in 2017. But basically, they developed what they called the Pandemic Severity Index, Category 1 through Category 5, based on a number of things, but the main thing they go by is the case fatality ratio. So how many people that get this and become symptomatic, not just get it, but become symptomatic from it, how many die? If it's greater than 2%, which is borderline where we're at, it's the highest category, on the equivalent of the 1918 pandemic. If it's, okay, so we're right there between Category 4 and Category 5. And I think it would be even fair to say Category 5, let's put those things into play. And so there were a number of things which are appropriate from a non-pharmaceutical intervention based on the literature at the time. Science, okay, science, not conjecture, albeit limited science at times, but at least science. And things which were discussed sanely with, with people, that have studied this for all of their adult life. And they developed these protocols, whether, voluntary isolation, voluntary quarantine, transient, less than 12 weeks, school closures, closures of like huge arenas and stuff, again, for an interval of time. So all of these things were in place. Nowhere on there was mandatory closing of businesses and closing of churches and mass quarantines and lockdowns and prolonged greater than 12-week school closures, community masking, and isolating of non-infected patients. In other words, shutting hospitals down to anybody whatsoever, even Providence Street coming in. Nowhere in there. All of that shit got made up after the Ferguson study. They just, for purposes of, they went into great detail in the 2007 document. In 2017, they updated it, so it's much less detailed, but just for purposes of transparency, I did want to mention that they updated this in 2017. It's basically the same stuff, except looking at it a little bit differently. Once again, none of these things are on there. So when we did that, we basically responded to media hysteria, is what we did. And we responded to an inaccurate study. And the problem is not that those things might not have some efficacy against COVID. I mean, it just makes sense. I mean, I can lose weight if I stop eating and drinking, right? That'll work. But there might be some downsides to that, And so what we're seeing is, I think, some real downsides. And I think to some degree, a loss of credibility. Well, if we could just hold on long enough, till we get a vaccine, well, maybe. But again, if people are dying from other stuff at a much higher rate than COVID, that doesn't make scientific or medical sense. Yeah, we can do these things without blowback, fine, but we can't. There's significant blowback. And if you think you're just going to outsmart the virus, let me tell you what, these viruses are smarter than all of us put together. Here's a study from 1973, 12 researchers, 17 months in isolation in Antarctica. Half of them got rhinovirus. Where the hell did that come from? 17 months, they got rhinovirus. So, we're not going to outsmart this virus with, we're not going to wait it out. Vaccines, I think there is hope for that now. And this is one thing we should look at. I do think we have to be careful too. Again, risk benefit, it makes me a little uncomfortable. I'm glad they're moving forward, but the rate at which we're moving forward does make me a little bit uncomfortable. And when they're saying things like we're releasing the company from all, medical legal obligations and we're not showing the animal studies and stuff, that bothers me a little bit. I'm not an anti-vax. fully vaccinated. I'm on board with that. Get my flu vaccines every year. You just have to be yelled at a few times, just remember to do it, but I do it. But I do think we have to be careful again to watch out for those unintended consequences. Because last time a coronavirus vaccine was attempted, it didn't go real well. There were some downside. The other significant downside of some of these measures is, to some degree, we might be hampering herd immunity. So what is herd immunity? Basically the concept that once a population, depending on the effectivity of the virus, reaches somewhere between 50 and 70%, there will be, enough people that are immune that it just dies out, and the R becomes, and the R times S becomes less than 1, and it dies out. So to some degree, by flattening the curve, are we also decreasing the amount of herd immunity we have in our republic against ourselves? Because how did the 1918 pandemic ultimately end? Did we have a vaccination? Nope. Basically, herd immunity ultimately killed it out. So to some degree, if we're keeping a number of people isolated, are we flattening that curve to the point that we're, impairing herd immunity? And the other concern, even with the vaccine, is that, this vaccine, whether they're talking 2 to 3 months of immunity, whereas more, naturally acquired immunity, how long does that last? I don't know that we know for sure, but clearly more durable in most instances than that obtained by vaccination. So there is some downside to some of this, which led 3 fairly prominent epidemiologists, one from Oxford, one from Harvard, and one from Stanford, to put out there this Great Barrington Declaration, which has now been signed by about 48,000 medical professionals, essentially saying the social distancing and stuff's appropriate, but the lockdowns are not. Open society back up. We're impairing herd immunity. They've been kind of vilified in the press, but to me, I think there is some significant rationale to what they're saying. At the same time, I think that we need to watch very carefully what's happening in Sweden, because while things did go very well in Sweden initially, now they are seeing, like we are, a resurgence. And they have actually now enacted some measures, not hardcore lockdowns and stuff, but they have enacted some measures because they've seen that their numbers have gone up. And so the Swedish experiment has not been as much of a validation of herd immunity as we would have liked to have seen, because it's estimated that to have any chance of significant herd immunity with SARS CoV-2 alone, decreasing the RS factor to less than 1, it's going to have to at least be 40%. Some would say maybe 30%, but at least 30 to 40%. Sweden right now, at least based on antibody studies that have been done across the population, even after this period of time, is only sitting somewhere around 7 to 10%. So our hope had been for somebody like me who kind of came from the mindset that I think there had been underemphasis on herd immunity, that's kind of a little bit of a refutation to some degree that herd immunity alone is going to get us there. And so I think that this is an evolving picture. We don't understand this virus necessarily, but what I think we need to understand is that we don't understand as much as we would like to. And I think that what we really need is a spirit of collegiality, and teamwork, and tolerance, and a loss of dogmatism and demonization and shouting at each other. But I do also think we have to keep in balance, individual rights and freedom for society. And I don't know exactly where that balance is at, but I think we've gone, too far off to one side at times. I think one thing we can't do is be dishonest. And so I'd just like to show a quick video if I can. Nick, why don't you come on up and be getting your stuff ready as I line out here. I'm sorry, I wanted to end up with those. So this is why I want to do this, over the next few months. I really am not. I know some of you probably think I'm trying to, force a political agenda or my views down your throat. That's really not my intent. My intent is for us to be educated and to learn from each other, because I don't know all the answers here. I'm not sure if I know any of the answers, but what I do know is this is a huge deal. And as physicians, we have, I think, a responsibility to be educated and to hopefully be a voice of sanity and calm during this.